Welcome to this episode of Anaesthesia on Air, the podcast from the Royal College of Anaesthetists. I'm Dr. Sarah Thornton. I'm a consultant anaesthetist at the Royal Bolton Hospital Foundation Trust. I'm also an elected member of the Royal College Council. Today, I am joined on the podcast by Dr. Ian Roberts, who is not only an anaesthetist, but much more excitingly, he works for the FIA, the Fédération Internationale d'Automobile, as the Vice President of the Medical Commission and as Medical Rescue Coordinator for the Formula One racing. Ian studied at Leicester Medical School and completed his training in the Midlands, and he's very keen on neuroanaesthesia, neurointensive care, as well as paediatric anaesthesia and intensive care. However, Ian now travels around the world to all the F1 Grand Prix events, averaging around 20 countries per year. He's one of the key medical staff on track and can be seen riding in the medical car at the start of every single race. Ian has started over 200 Grand Prix, but unfortunately he hasn't won one yet. Now, Ian, welcome to Anaesthesia on Air. So, how did you end up on the Formula One grid?
Good morning, Sarah. Thank you very much indeed for inviting me along. A real pleasure to be having a chat with you. I got into officiating into motorsport relatively late. I've always enjoyed watching motorsport, but never really been satisfied just watching. I've always been very keen to be getting involved with things, and I mentioned this to a colleague when I was a registrar, and he said, "Oh, there's somebody I need you to meet." In fact, I think we were at an association of anaesthetists meeting in Birmingham, and he took me along to see Dr. David Cranston, who at that time was the Chief Medical Officer for Silverstone. Unfortunately, David had to leave early, but eventually I got to see David, went down to Silverstone to meet him, and invited to join the medical team there. And I started off trackside in all weathers, serving my apprenticeship, as it were. Eventually, or because I just continued to go, I really enjoyed it. Went to the various national, international meetings, and I sort of graduated from trackside into one of the fast medical cars. Worked in the medical centre. And that's as I became more senior in terms of my anaesthesia practice. And I was invited to join the Grand Prix medical team. David was also Chief Medical Officer for the British Grand Prix. And as time went by, I became David's deputy, and then ultimately the Chief Medical Officer for the British Grand Prix. And that's where I worked very closely with the FIA medical delegate. And there was a change in staffing that was happening with the FIA, and I received a phone call. I think was out walking the dog or something, and I had this phone call, and they said, would you be interested? You don't have to give us an answer now, but would you be interested in joining us as a medical rescue coordinator for Formula One? I think I took about 10 milliseconds and said yes. So that was it. That was in about September 2012, and I joined F1 for the 2013 season, and that's so I did my 10th season last year.
Wow. So you travel around the world for every single Grand Prix? You go to every one? Yes.
And although it sounds extremely glamorous, it's well, I suppose it is. I mean, at the races, it certainly is. But it's a lot of travel, lots of jet lag, hotels which generally are okay, and lots of time away from home. So it's a double-edged sword, really. You can't do it without spending time away. And you put up with the not discomforts, but you just put up with the time away.
Do you still manage to do some clinical work as well?
In terms of clinical work, yes, I still manage part time. which was reasonably substantial at the beginning when there were not so many races. But as the years have gone by, they've added more and more races, so it has become increasingly difficult to take part in clinical work. But I still have done, still maintain skills which have been quite useful over the years when for certain interventions. And maintain my registration and clinical practice. I do work alongside a national doctor when I'm away. The rules are that there has to be a national doctor in the car with me, because that's part of the liaison process with the local medical team, and that works extremely well under most circumstances. The skill level of the doctor who is with me does vary in terms of their motorsport experience, but they generally are doctors who are very experienced in their own specialty. It's just that they may lack the exposure to the motorsport side of things. So I have to keep them safe, as well as keeping the driver and myself safe, and allow them to apply their skills should it become necessary.
So that must be a very interesting and slightly difficult part of your role, is integrating yourself into different medical systems throughout the world, because there must be some quite big differences between how they do stuff, or is it the basics the same?
The basics are the same, but there is a quite a large amount of diplomacy that has to go on. We go to 2022, in fact this season 23 different jurisdictions, and the FIA sets a standard which all of the circuits and medical services have to abide by. In virtually all the cases, those standards are exceeded, but we still have to work within the local framework, and we have to allow for some regional variation. The rules are set so that there is a basic minimum, and in the past it's been quite telling that some organisers, not the medical people, but the organisers, want to get away with us and pay for as little as they possibly can. So we can go in and say, well, actually, if we're not to a certain standard, the race doesn't happen. In my 10 years, we've done it once or twice. We've had to really put our foot down and say this isn't acceptable. But on the whole, it is. The medical staff, it's very much dependent upon whether they have a very big motorsport presence. For some countries we go to, they do very little motorsport, either amateur or professional, and they may just have a Grand Prix. So the medics, doctors, paramedics, nurses, they don't have the exposure to the types of or the application of pre-hospital care within the motorsport arena. And sometimes it's quite amusing because they'll put someone forward who is highly skilled, but unfortunately they don't know how to apply it in our particular situation, and that's not their fault. That's it's just a matter of fact.
So how is part of your job actually training these people to understand what's going to be required of them?
Sometimes it is. What we expect when we arrive is that the team have been trained to a minimum standard, that they understand how to intervene in an incident, that they have an understanding of the application of their skills on a track. There are times when we do need to do some remedial work. For example, we've had times where we've been away and the extrication teams have been not up to our standard, and we've spent some considerable time training them. again, it's usually because they don't have a background of motorsport, and a group of paramedics, for example, or firemen, or marshals have been brought together, and they've done some training, but it may be not quite enough. And we normally arrive on a Wednesday before an event, and we have to go through some form of training or remedial work.
So tell me about this extracting someone from a car. So what modifications do you insist on in the car? How much influence do you have in making a car easy to extricate someone from?
There are quite a number of different techniques for removing a driver from a prepared race car. Now, the technique will vary whether it's a saloon or a single seater. So mostly I deal with single seaters now. I used to do rally and I used to work with saloon cars. But for single seaters, there are a number of construction rules whereby the monocoque, which is essentially the survival cell, is fitted with an extricatable seat, which means that the driver can be removed from the car in his seat, and so he's basically there are already straps and clips integrated into the seat. The driver is immobilized in terms of C-spine and head by some additional equipment which the extrication teams carry. He or she is strapped in, and then the whole seat is lifted out, and then the driver is removed from the seat and transported to the medical centre, usually on a beanbag.
I was just going to say that those beanbags, that you suck the air out of. Is that the ones you mean? The vacuum sealed ones?
Yeah, exactly that.
What's in your car in terms of kit? What have you got? Is it the usual sort of anaesthesia transfer bag, or is there a lot more to it than that?
Well, I sort of work on three levels. In my race suit, I have some clinical gloves. I have an airway. I have some shears, and that sort of gets me out of trouble in sort of 95% of any incident. So I can intervene with an airway. I can cut things, and that's where we start. Then, actually, in the car with me, I have a small trauma bag. It's size of a sort of a modest size handbag, I guess. And in that, I have again some airways, eye gel. I have a BVM which is collapsed down into a little container, IV access, a few more bits and pieces of cutting equipment, a couple of tourniquets. Oh, sorry, I should also say I carry a tourniquet on me. And then, should things be going really badly, in the back of the car there's a trauma bag, so I can do a video guided intubation. I've got cricothyroidotomy. I can do tracheostomy. There's sternal intraosseous device, some fluids. So it's a trauma bag that basically we can up the ante if necessary. I carry some burns dressings. Technically not dressings, but they're for cooling. We don't carry water. We carry the burns cooling dressings. Defibrillator monitor. We carry two extinguishers, one powder and one which is water based, so we can, if necessary, extinguish fire. But we're not focused on the car, we're focused on the driver. So that powder is to put out either the driver or me, if it comes to it. We also carry a cutter, so I can cut the halo. And alongside of that, the national doctor also brings a trauma kit, so we can look after two drivers at any one time immediately. And then, of course, that's when the cavalry arrives. So what tends to be forgotten is that we work with a medical team. So there'll be 3 or 4 other fast medical cars, 2 or 3 extrication teams, a variety of ambulances, and there will be, depending upon the circuit and the circumstances, there'll be a number of trackside doctors on foot. So whilst we're the first intervention, there are plenty of other resources to be sent to us.
And how many of those interventions you've just described do you have the kit for? Have you had to do in anger over the last 10 years?
In anger, probably 3 or 4, because we're there when the other safety measures are surpassed or compromised. Over since 1978, really, when Professor Watkins got involved with Formula One, the safety elements in Formula One have increased tremendously. Up until 78, there were several deaths a year in Formula One. From 78 onwards, we're probably looking at 4, because of the way that the engineering and the safety elements have been developed and put into Formula One in particular. Now, Formula One's a special case in that that those elements are put in, and of course it should trickle down into sort of other professional and amateur sport, and it has done. But motorsport still is, as the ticket will tell you, motorsport is dangerous, and there are a number of serious injuries and fatalities every year worldwide. But Formula One, no, we've seen huge leaps in safety in the early days, and of course the FIA, through its safety and research and engineering programs, have improved driver safety no end.
So I know we have lots of telemetry on the cars, but is the telemetry on the humans? So do their teams or you monitor their heart rate, all those kind of physiological parameters? Is any of that monitoring going on during a race?
Yes, I'm personally involved with the biometric glove. Alan and I. Alan is the medical car driver. We saw an issue that particularly came to a head with Carlos Sainz when he had his crash in Sochi, that we had limited access to him, and thought, well, wouldn't it be good if we'd already got some monitoring on the driver? So between us, we developed the biometric glove that is used in F1. We developed the electronics and also the sensor. So the glove will monitors pulse oximetry, and it monitors motion. So we can actually see during a rescue, we can monitor the driver, and via sort of different surrogates, we can imply on the condition of the driver. The glove is monitoring the driver all of the time, and all of the data is stored in the electronics in the glove. But I only interrogate the electronics when the driver becomes a patient, because until that point, that's all performance data. So that's it. Once the driver becomes a patient, then I can monitor him, and the data only comes to me. So although we can send the data to race control, it's kept with me for data protection purposes.
So the teams don't sort of monitor their drivers' physiological parameters in any way?
Well, we know they do, but they shouldn't. There are strict rules about anything that, there are strict rules about what touches the driver, and anything that touches the driver's skin has to undergo an homologation process, which we did with our sensor. So basically, our pulse oximetry sensor is encased in a silicon which it does not transmit heat, but also can survive fire. So our sensor can actually survive up to 900 degrees. The glove will be dust, but our sensor survives. So it's a bit of a crazy level of requirement, really. But they do put things on the driver. They put ECG electrodes. They put things like the chest monitoring straps, but actually they're not supposed to. That's against the rules, unless it's been homologated. And to my knowledge, there are no homologated monitoring devices except for the biometric glove.
So, is your role just during the race, or do you look after the drivers outside of the race environment?
All of the drivers in Formula One have a medical team that's responsible for them. So it's usually a private arrangement. Either as an individual or several of them will employ a doctor or paramedic to look after their sort of general well-being. But they have huge resources at their disposal. They, performance coaches, physiotherapists, sports physicians, and that very much depends upon their budget and what the team are likely to pay for. So the answer to your question is no, I don't, except for to ensure that their declared fitness for the purposes of their super license, that they are fit to race, and they abide by those particular rules. If there is an issue that that would compromise their license status, then yes, we are involved, and we do everything we can to ensure that they can be reintegrated should they have had an injury and their license is removed. So we try and get them reintegrated as soon as we can, depending upon their medical condition. And then at the race, again, they would be generally looked after by their team. But should there be an incident on the track, then myself and the other medical delegate, because there are two of us, we would then take great interest in their care and recovery. So mostly the trauma side of things. Although I have, on occasion, needed to be involved with other medical issues. If they have to go to hospital for anything else, for example, if it would impinge on their license condition, then I would need to know that.
What other physiological stresses does a racing driver undergo? So they undergo G-forces, don't they? They have monitors for G-force. Is that right? So, and they also get dehydrated, don't they?
Yeah, the G-forces are. They certainly train for the constant G-forces that they're under when they're actually driving. We're certainly interested in the G-forces that the driver experiences during any track incident. There are accelerometers on the car. There are also accelerometers in the driver's radio earpieces. And should the driver be involved in an incident, then we interrogate the accident data recorder, which is truly the car's G-forces, but is a surrogate for how the driver or what the driver has experienced. But later on, we get to see the G-forces that are applied to the driver's head through the earpiece G-forces. The dehydration, as you mentioned there, it can be quite severe, and one of the very first times I had to extricate a driver was not through an accident at all, and it was at the time GP2 driver, because we have other series with us, and he drove into the pit lane post race and couldn't get out of his car. He'd almost literally got total body cramp. He was so dehydrated, and he was in agony, and we literally had to lift him out because he was in such a state, and he had to go off to med centre for sort of some rehydration therapy. But yeah, the drivers, depending upon the conditions, certainly can lose several litres of fluid, which is why sometimes when you see them out and about on the parade laps and things, they're busily sucking away on their bottles of isotonic drinks, etc. So by the time they've all filled up doing that,
do they not just need a wee then halfway through the race?
Well, they do, but the other thing is, so that they're busily topping themselves up at the beginning, but as soon as they have taken the cars out of the garage and put them on the grid, that's where you see them all running off to. They're all off to empty their bladders, and they're for all that fluid. So yeah, there's normally a queue of the toilets for just before a race, which is quite.
How funny.
Yeah.
So you mentioned safety, and it's a really big part of your job. So how much influence do you have on safety measures? Are there new ones in the pipeline all the time? What are the ones you think have made the most impact? Sorry, that's a lot of questions.
We do get to comment for sure. I mean, if we have any incident, there is an investigation into every single incident to see why it happened and if there was anything else that might sort of ameliorate the consequences of the accident. Because motorsport is dangerous, and safety is one of those real odd words about motorsport. We basically manage risk, we mitigate risk, because otherwise we might as well just dress the driver in some cotton wool and put him in front of an Xbox. So there is going to be a risk, and what we're trying to do is manage it. So the risk management comes down to, in my mind, two main things. That is regulation, and that's actually ensuring that the circuits make their tracks as safe as you possibly can, but they retain excitement for the driver doing his work, and also for the spectator. So putting and ensuring that there are appropriate barriers, runoff areas, those sorts of things. There have been big changes over the years in terms of the types of barriers that are used. I mean, traditionally we use tyre barriers, but there's continuing monitoring of the way that tyre barriers are used. There are things, the other barrier, Tech Pro. There are others, but Tech Pro is the main one that we use in Formula One. And the presence of that and arresting a car and reducing the energy that the cars have, bringing it from a couple of 100 miles an hour to zero in a very short space of time. There's a lot of engineering goes into those things, and then engineering for the cars and making the cars safer for the drivers to be in, so that they don't fall apart. Although when you do see a crash in Formula One, it looks pretty horrendous. There's carbon fibers going all over the place, but that's designed to do that. And the central bit, the monocoque, the safety cell, that is fairly impervious, but still things happen, and you can't engineer your way out of everything. The problem with engineering is that you solve one problem, I mean, sometimes you just move it somewhere else. There was a tragic accident. There was a tragic accident a couple of years ago in Spa, in Formula 2, and in fact the side panel of the monocoque was pushed over because of the T-bone accident that he had. And there's a lot of work now on the 2024 Formula 2 car to strengthen all of that. But if you strengthen one part, you basically move the weakness to another. So there's a lot of, not necessarily compromise, but there's a lot of clever engineering got to go in to make sure that the whole thing remains a firm and protective structure.
So the hands, the head and neck support thing, how effective is that in terms of keeping their head and neck immobile?
Very effective. I mean, we've certainly not seen any of the in recent times the horrendous injuries that the drivers used to experience prior to hands. Both.
How interesting. So they now recognise the importance of them. They acknowledge they make a difference. They must do.
Oh yeah, absolutely, and it's, the same went for the Halo. The Halo was probably, I could say, universally hated as an addition to the car. It certainly doesn't look great, but now, as a consequence of a number of impacts, again, that has proven to be a lifesaver. And but a lot of the drivers, no, they really did not like it at all, and a lot of motorsport fans didn't, which is an interesting one. They often use the phrase it was not part of the DNA of Formula One racing, but as anybody who believes in evolution, DNA changes, so therefore so should the cars. But
right, we're going to have to leave our chat with Ian there, and I hope you will join us soon for part 2 of this podcast, where we'll hear more about the fascinating medical world behind Formula One.